Hi, so yeah, echoing Professor Green, so just like to welcome everyone to the Virtual Access 2020 conference, which has kindly been set up by some of the core surgical trainees in London. So this is being the first year that we started running this. We're hoping it's going to go like clockwork, very smoothly, but it's the first time a lot of us are using this hop-in software. So we apologize in advance if there's any sort of clangers along the way. I can see from the top here that we should have 13 people watching the session. Can I just confirm, if you guys are able to just confirm in the chat box, are you able to firstly hear us and see us?
Excellent, very positive feedback. No?
Excellent, excellent. So that seems like, yeah, it seems like it's working well for everyone. Okay, good. So firstly, just to, and I'll let both our moderators introduce themselves, but just to thank Professor Green and Ms. Zachou as well for joining us this morning. They're going to be moderating the urology sessions. I don't know if you just wanted to say a quick hi to everyone.
Hi, sorry, James Green. Hi, if anybody doesn't know me, I work on BARTS, but I am in lead for the equipped program for BAUS, which is to do with quality improvement. So if you haven't seen me before, you'll see me when you all get numbers at the Leeds boot camp, where I'll be talking to you again then. So good luck with your applications, everybody.
Good morning, I'm Alexandra. I'm a senior urology trainee. It's an absolute honor participating to this thing, and I wish you all the best. Very, very interesting work. Thank you.
Fantastic.
Yes.
So just, I guess, just for some sort of housekeeping and from the order of the day, the plan is that there's going to be, there's 1, 2, 3, 4, 5, 6, 7, 8 presentations, 10 minutes each. It's going to be 6 to 7 minutes per presentation. And then Professor Green and Ms. Zachou will take it in turns of asking some questions at the end of the presentation. And then if you could just sort of answer them or just engage with the discussion to the best of your ability, that'd be perfect. I think the way that we're going to do it, you should have received an email with some instruction, but if you ask to join, so I think first up will be Josie Colmeadow. So not yet Josie, but in a moment when we ask, if you could join the discussion, we then should receive an invite for this. We can then invite you into the conversation. And then when you're ready in your own time, if you want to start the presentation, and we can all hear it. If there's any problems along the way, if you can just write in the chat box. I'm going to, 2, 3, 6, 1. I'm just going to put my mobile number in here as well, just in case for some reason there's problems with the internet connection, the chat box isn't working, or for whatever reason, someone can bring through. We are aware that, as I said, that this is a new technology. It'll be the first time a lot of people are using it, including ourselves. If there are any technical glitches, just be rest assured that, you know, we won't let this impact on your presentation, and we'll do our best to make sure it's fair and you guys can have ample opportunity to just present the work you've been working so hard on. And again, just to say, from actually looking at the abstract as they all came through, we're really impressed at the high quality of them, and there's some really good projects that are going on up there. Okay, so I think we're probably ready to start if you guys are. So Josie, are you ready? Are you expecting to go first? Okay, great. So if you join you're able to request to join, fantastic. Okay, so hi Josie, can you hear us? Josie?
Hi, can you hear me?
Hey Josie, yeah, we can all hear you.
I'm just trying to work out how to share my screen so I can get my PowerPoint up.
No worries. So it should be, there's it's the third icon along the bottom. There's one that's like a computer.
Yes, I've got it.
So if you press that, and then there's the option for sharing your entire desktop or just your Chrome tab or whatever internet browser you're using.
Calum, should we leave and rejoin, do you think, the moderators, or for a bigger screen, or can you get Josie up on a bigger screen?
It might be. I think maybe that's the maybe we should leave and rejoin.
Okay, I'll leave.
The first one. if you guys just want to leave and then just comment, just double check that you can still hear everything. So Alexandra, do you want to just leave the conversation as well?
I just press the leave thing there.
Yeah,
Okay.
just the thing. That's it.
Calum, can I just ask a quick question? When I share my screen, I press application window and then the PowerPoint app isn't coming up. If I press it and then go on it, will it, do you think it will show? Or
It should do. So it should just be an exact grab of your screen.
Yeah, okay, fine. George, shall I try that now?
Hang on, Struan's just kindly commented, you can make a screen full by double tapping it. That saves from having to leave and rejoin. Oh, right, okay, so hang on, so is that Struan? Are you basically saying that if you guys as watching it, double tap Josie's screen becomes full screen for you guys? Is that right? Perfect, all right. Hi, Professor.
Okay, I'll come back then, knowing that.
Yeah, amazing, amazing, thank you.
Just makes things quicker.
Shall I try it? Right, shall I try and get this to work now? Just give me one sec. I see. So do I have to present with looking at my slides, if that makes sense?
I think it's in, so your slides be on the screen rather than you.
I think that's the way I'm going to have to do it.
Yeah, that's fine. We don't have to see you, Josie, though it's very nice. You can talk to your slides.
Can I just confirm that you can all see the start of my PowerPoint now?
It's still a picture of you, Josie.
Oh, no. Okay, sorry about this, guys.
No, it's all right. It's difficult.
As I said, the first one will be a steep learning curve for us all, and then hopefully it just continues to get...
Okay, so screen share, applications.
I'm going to take off my screen share.
Some reason when I scroll across and go onto it, it's coming in, but when I don't, let's try. Just give me one sec. I'll try something.
No problem. No problem. As I said, we've got lots of fat built into the session just for these sort of these learning curves. So not to worry at all, Jason. That's it. So we've got the yeah. It's come up with a new one saying, but it's PowerPoint. So I'm just going to try it. So I've clicked it twice, and that's come up in the full screen. And just to double check for Professor Green and Zachou, can you guys see that across the top of your screen?
I can see that beautifully. Yeah, well done, Josie.
Perfect, well done. And Josie, we can actually still see, just before you start, we can still see your video underneath as well.
Exactly.
So
it's all good.
Okay.
It's all good.
Don't do anything I shouldn't. Yeah.
Okay, so Josie, I'm just going to, 1 second, I'm just going to start my timer. So yeah, so in your own time, just whenever you're ready, Josie.
Okay, so hi everyone. I'm Josie. I'm a CT1 in urology at the moment, and I'm working at North Middlesex. I'm in the middle of nights at the moment, so I have woken up to present. So I hope I make sense, and if I don't, I apologise, and I'll answer any questions you've got at the end. I'm just going to briefly chat to you about a project that I worked on at North Middlesex, and it was aiming to reduce on-the-day theatre cancellations in urology due to a positive urine dip or asymptomatic bacteria. I'll just give you a brief overview of how I went about this. So asymptomatic bacteria is where a patient has significant levels of bacteria, so it's over 10 to the 5 colony forming units of the bacteria per mil of urine, but they don't actually have any symptoms of infection. So in urological procedures where the urinary tract is entered and the urothelium is breached, it is actually a risk factor for post-operative urinary tract infections and also sepsis. And international guidelines at the moment, like the EAU, AUA guidelines, state that it should be tested for, and antibiotics should be given if asymptomatic bacteria is present. So what I noticed during my time in urology is that actually there were quite a lot of cancellations on the day, either due to a positive urine dipstick in a patient or for urine cultures that have been taken that have grown bacteria but the patient doesn't actually have any signs or symptoms of infection. There wasn't any clear guidance on how to manage it. It was kind of a thing that each clinician would manage in their own kind of way due to their own experience. And what I noticed is that it is actually very common. And if someone didn't check on the urine culture a couple of days before theatre, and on the day, if they had a positive urine culture, it was almost like they were almost always cancelled. It's common, you know, in patients with catheters or stents or staghorn stones. These might be colonised, and this asymptomatic bacteria is very, very common. So it was leading to lots of cancellations. So this is a brief overview of the audit that I did. Just looking at these cancellations, and I wanted to see what the kind of sequelae of them was. So in a 7-month period in the beginning of 2019, there were 18 cancellations. This was due to either asymptomatic bacteria or a positive urine dip. So only 78% of these actually had a urine culture in the month leading up to surgery. When the operation was cancelled, the average time from cancellation to rescheduled procedure was 57 days. And actually, during this time, a third of patients were admitted with complications or problems directly linked to the delayed procedure. So an example I will give is a patient awaiting a TURP or a TURBT, readmitted with bleeding and clot retention because of a bleeding prostate or a bladder tumour that's bled and caused them to go into retention. So that's quite a high number, I thought. 2 patients actually died waiting for the procedure, and 1 patient, when they did eventually undergo their procedure, was admitted with a severe infection, which would have thought not to have happened if the procedure had gone ahead as planned on the day. So I had worked closely with one of my consultants, Mr. Alm Panis, and the microbiology team at my hospital, and we created a guideline that hoped to kind of dispel any myths and create a uniform pathway for how these patients should be managed. So we originally called it the Urology Pre-Assessment Pathway for Asymptomatic Bacteria. We did actually include patients with and without symptoms of a UTI, because if a patient has symptoms of a UTI, they should be treated and the procedure should be rescheduled. It also includes a step-by-step antibiotic ladder for patients. It also, if you follow the guideline correctly, eliminates the need for a urine dipstick on the day of surgery. So hopefully preventing any patients being cancelled for positive urine dipstick. And if they have asymptomatic bacteria, they would have been managed appropriately. So I'll just give you a little quick overview. This is the main sort of flow chart on how to manage these patients. This is the part I was interested in, mainly because this is the management of patients who don't have any symptoms of a UTI. So as you can see, I don't know if you can see my arrow here, but on the left, if they have this significant bacteria, after speaking with microbiology, having a look at the guidance, we decided that these patients should take antibiotics for 3 days before surgery and have their standard intra-op prophylaxis, which at our trust is gentamicin. And as I mentioned previously, you don't dip the urine. If they've had those 3 days of antibiotics, you assume they're covered, give them their intra-op prophylaxis and carry on as planned. If patient has mixed growth, we just give the intra-op prophylaxis. Now, to kind of make sure that all patients were covered and to avoid any confusion amongst, this is the antibiotic ladder that we devised with the help of the microbiology team. So I think it's quite clear. It indicates green and red according to penicillin allergies. It also indicates renal function and what should and shouldn't be given. And it allows sort of escalation according to culture results and sensitivities. This is the side where we cover patients who did have symptoms of a UTI. So we basically would send off their urine for culture. The SHO on call will review the patient, review their symptoms, and prescribe appropriate antibiotics for a UTI if they deem it necessary. We then follow up 5 days later with a repeat urine culture. And then once they've had that, they rejoin back at the beginning of the flow chart and have their standard pre-assessment done again. And there was also liaison with the consultant and the team to make sure that is done within a good enough timescale that the patient doesn't miss their surgery. So this has been implemented within the last month and a half. We wanted to make sure it was safe. Obviously, it's a new guideline for us at North Middlesex. So we have asked the IT team to, the informatics team, very complicated, but they can tell us if anyone comes in who's had a urological surgical procedure within the last 30 days, and if they present with sepsis or a UTI confirmed on urine culture. And also, we haven't had any reports yet, but if there was an abnormal increase in the number of cases, we would put the guideline on hold. So obviously with COVID, our hospital is split into 2 different zones, and pharmacies in one zone and the pre-assessments in another zone. So it all makes it a little bit more difficult. So we're currently in talks with how we can fit this guideline with the new COVID regulations. The thoughts are that we're going to make pre-packs of antibiotics that the pre-assessment team have that they can just automatically give out, so the patient avoids having to go to the pharmacy. We're going to reaudit within the first 2 years just to have a look and see how this guideline has helped, if it has reduced on the day cancellations or if it's in fact stayed the same or even got worse. We have frequent urology business meetings and team meetings, and we have presented this guideline to the pre-assessment staff, the anaesthetist, the urology team, the theatre managers, theatre staff, everybody involved, so that we all are on the same page, and also tell the day surgery staff who admit the patient and do the urological checklist to make sure that the procedure has been followed as planned. So that's just a very brief overview of what the policy we implemented and the audit that we had a look at. Happy to answer any questions.
That was fantastic. Thank you so much, Josie. It was great presentation. I think Professor Green is going to kick off the questions. Ran a couple of minutes over time.
Hi, Josie. Thank you very much for that. Thank you. Yeah, can I just ask, treating symptomatic and asymptomatic, I mean, some people would say that, if the MSU is negative, the dipstick's positive, and they're still asymptomatic, you might just, as you say, load them with antibiotics and continue your work. How much do you think you're going to save by this? How much do you think you're going to improve your cancellation rate? Have you assessed what percentage will improve the situation?
So because it's only newly implemented, we haven't got any data yet from what we have introduced, but in my initial audit, one of my consultants actually kind of devised his own practice and decided, basically patients in the scenario you said, where they had a positive urine dip, a negative culture, no symptoms, he gave them a treatment dose of antibiotics on the day of surgery and then sent them home with 3 days of antibiotics. So we had a look at 10 patients it was that he did this for within the last couple of months in comparison to the other patients, and none of them were readmitted with any post-op complications. None of them had any post-op infections or UTIs or sepsis. So his results were kind of promising, but we're just hoping that now we can prevent the cancellations, because obviously 18 cancellations causes a lot. It's patient frustration, extra money for the trust, a lot of delayed, blocked out lists where other patients could have been utilised for their surgery.
No, I realise that, but what percentage of that is? So you've done your audit, you've realised that's a problem, but this, you say you had 3 pathways, didn't you? And they're not all addressing that. Some are patients that will still need to be cancelled. So what I'm trying to say is what impact do you think that'll make on your cancellation rate? Is it improving it by 30%? Is it improving it by 60%? What are you projecting it to be with your new guidance? Or do you think, because I don't think you'll ever be able to stop cancellations for
yeah.
So I'm just saying, what do you think your projected saving might be?
So for specifically for patients with asymptomatic bacteria, no signs of infection, and a positive urine dip with no signs of infection, our aim would be that we completely avoid 100% those cancellations.
Yes, but what percentage is that? That's what I'm trying to say. What percentage is that? of your group that are being cancelled currently for UTIs?
You mean cancellations for UTIs in comparison to all cancellations?
Yeah.
So it's about, when I looked at the data initially, the cancellations in urology is about sort of 30-40%.
Yeah, that's what I expect. Yeah, that's what I was just wondering. Thanks. And then my last question, because we've got to get on and let everybody else present, is if you took this further on as a quality improvement project, how would you like to see it expand, or how do you see it? I know you've done some, obviously, projection. You're using IT. Do you think that's good enough, or do you think you need to do other things on top of that to assess it?
So we did the IT just to make sure that we didn't miss any kind of alarming rise in complications. Looking forward, I would ideally like to look at all the urology cancellations and just kind of evaluate that and see what else. There are a lot of cancellations due to theatre lists that have run over, which is obviously difficult, but in a lot of cases it's because there's been possibly too many cases scheduled. So we are having a chat with a couple of my consultants to look at just generally the other cancellations and how we can reduce those as a whole, because there were quite a lot during the time period that we looked at. Okay,
that's great. Sorry, we better for time carry on with everybody else, but thank you very much for that, Josie.
No worries. Thank you very much.
Thank you.
Josie, fantastic. Thank you so much. So if you could just kindly exit from typing, press the red minus sign, and that brings you out. Fantastic. So next up we have Thomas Thompson. So Thomas, if you just, perfect, right on cue. Good morning, Thomas. Thank you for joining us.
Can you hear me?
Yeah.
Okay. Thank you very much for inviting me. Let me just work out how I'm going to share my screen.
Yeah, fantastic.
Does that seem to work? Can you see?
It was it. That's it. It's working there. Perfect.
It's working there. Perfect. All right. So thank you very much for inviting me to speak. So my name is Thomas Thompson. I'm one of the urology trainees based in the Northwest. And I'm going to give a brief presentation on a recent study which I conducted looking at patient-reported outcomes during the COVID-19 pandemic. So, as I'm sure you're all aware, there's been a recent explosion in remote consultations, or also known as telemedicine, and this has been due to new guidance from NHS England dating back to March this year, which imposed that all consultations should be done by remote consultations as the first line, unless patients met specific criteria. So the obvious reasons for this were to reduce the risk of transmission amongst both patients and staff, as well as to allow virtual assessment of those patients who are shielding or self-isolating. So obviously, most healthcare professionals have had some sort of hesitancy about the safety and suitability of remote consultations, but also about what patients' perception would be to this new sort of way of outpatient medicine. So our study looked at assessing patients' perception and satisfaction for remote consultations, and we hypothesized that for various urological conditions, patients would find telemedicine both convenient, efficient, and effective. So how did we do this? We collected data prospectively from a single tertiary urology unit, and there were 122 continuous patients who were recruited from consecutive outpatient virtual clinics, which were conducted by 2 urological consultants. All of these consultations were done over the telephone, and 100 patients successfully completed the questionnaires. So what primary outcomes did we look at? So firstly, we looked at patient satisfaction. This was done using a 9-part questionnaire, which looked at it was a 9-part questionnaire, which asked patients to rate their satisfaction from a scale of 1 to 5 using a Likert scale. The same 9-part questionnaire was used to assess patients from the new remote consultations compared to previous face-to-face consultations. And this was done using a patient global impression of improvement from a scale of 1 being very much better to 7 being very much worse. Finally, we asked patients what they would prefer in the future for the follow-up of choice, being either face-to-face, remote consultations, or a combination of both. So now moving on to results. Here you can see the first questionnaire. So this was looking at patient satisfaction. There was clearly very good results here with a median score in excellent for all 9 questions. And importantly, patients reported a positive experience with 97% rating their overall satisfaction as either good or excellent. Nearly all patients, also over 98%, rated their convenience of the remote consultation as good or excellent, as well as feeling comfortable during their consultation. This next table shows the comparison between remote consultations and face-to-face. And here again, you can see that convenience was reported as significantly improved when you look at remote consultations, and this showed that 87% of patients reported this as an improvement. If you look at all the other factors though, there was a median of no difference, and this isn't unsurprising, but also reassuring that patients didn't see remote consultations as a negative compared to face-to-face. And also importantly, 40% of patients reported that there was an improvement in overall satisfaction, and just under 90% either found there was an improvement or no difference. So what did patients find they would like to do moving forward? So here you can see that there was a significant proportion of patients, 70%, would prefer a combination of both remote and face-to-face consultations, with only 17% wanting to revert back to purely face-to-face, and only 13% wanting to move forward with remote consultations only. So what conclusions can we draw from this study? So obviously you can see that this study demonstrated that remote consultations achieve a very high patient satisfaction rate and are a well-received alternative to face-to-face consultations. Importantly, there was noted to be improved convenience, or at least equivalent or improved overall satisfaction when comparing to previous face-to-face consultations. So therefore, we can conclude that remote consultations offer a viable supplement to face-to-face consultations to improve efficiency and also provide a positive patient experience. Obviously, at the moment, there are significant restrictions to outpatient medicine, so this is an important field of medicine to explore. But also past the pandemic, as there's always an increasing demand on outpatient medicine, it can offer an opportunity to expand this. The future research we need to look into must account for the long-term safety of this, but also to look into which urologic conditions or patients can be particularly targeted to undergo remote consultations. Thank you. Thank you very much for listening, and any questions? I'll sort of move back to the... All right, thank you.
So, Thomas, congratulations. You addressed a very big question mark in the minds of all urologists about how going forward during COVID period. Would you kindly remind us what are the exclusion criteria for the telephonic consultations, please?
So, yeah, so it depends on the guidance that you look at. So NHS England actually give it very much open to individual departments. So they advise that within an individual department, you set your own criteria. So I think for urologists, it is variable depending on the department, but a huge thing is whether patients can be appropriately assessed. So certain things with particularly elderly patients or patients who will struggle to communicate either over the phone or through video consultations, those patients which it is necessary to do a physical examination. And I think one thing that has been highlighted to us is also assessing patients' fitness for certain procedures that very much you can ask a few questions over the phone, but seeing a patient physically can very much impact whether you can make that decision, whether you think they're suitable to undergo a procedure and an anesthetic.
Absolutely. And can I possibly ask you what made you decide upon these two questionnaires, like the Likert scale and the global impression of improvement.
Yeah. So that was one. So unfortunately, one of the limitations within this study was there is no sort of set standard or validated questionnaire looking into remote consultations. So I sort of trawled through various previous papers, and obviously the patient impression of global improvement is previously validated, but not in this setting. So we tried to find which questionnaire had enough criteria appropriate, but also were aware that that was a limitation within the study.
Yeah, absolutely. Okay, then.
Can I jump in and ask a question as well? Would you mind? Basically, 17% only wanted to go straight, completely to face. Do you find? I mean, that's interesting, isn't it? We've done a similar study and found virtually the same. And do you think that's cultural? Do you think we can persuade people more that that remotes are the way forward, or do you just think people like coming to see, like paying the parking charges off?
Yeah, I think it's a difficult one. I think a lot of these patients were follow-up patients, so I think that also will impact people's opinion. So I'd imagine that new patients to a service would prefer to come in and meet their consultant or their clinician for the first time. Whereas if you're being followed up for a procedure that happened, say, a year or 2 years ago, and it's a simple, is everything okay? Yes, I very much prefer that to have that conversation over the phone. For us, one of these consultants was an andrology surgeon, and very much he's a tertiary service with patients traveling 40, 50 miles to come in for an appointment. And therefore, you can see why remote consultations would be the preferred option in those cases.
Yeah, I think you're right. I think I'd temper your conclusion. I think it's horses for course, isn't it? There are different environments, different people, different traveling, different times in people's pathway. I completely agree with you. I think new patients are different from and lots of other reasons you said. Just so everybody on the call is watching in, we are happy to take questions from the floor as well, just so people know that. The other thing I was just going to ask you is sampling bias. Obviously, you're asking the people who actually managed to get through and are successful. What about all the other people who we have, I try and phone loads of people up in remote consultations and find that I can't get through. We've got wrong telephone numbers. We've got this and that. So there is a little bit of a sampling bias, isn't there?
Yeah, no, definitely. And even to be honest, I think even because this was a lot of the data collection was at sort of the peak of the pandemic, which meant most people were at home and able to answer the phone. So an over 80% response rate for any questionnaire is extremely high. And so that was probably slightly different to what would have been in normal circumstances. Obviously, with one of the things that was probably the most negative was the actual information prior when taking the responses for that. And a lot of that was because they never received a phone call from the secretary because they didn't answer it at that time. So yeah, there's definitely a sampling bias there with patients who are unable or who just don't get a chance to answer the phone.
Great. Sorry.
That it is a very big problem for every quality assessment questionnaire. So as you said, the validated thing is much more helpful, and obviously all the biases in association with the circumstance of the individual, the time frame, the primary pathology, all of these things do affect what is happening in this challenging time. And many departments are introducing video teleconferencing, so it's another important bit.
Yes, definitely agree.
Thank you for doing the work then. It's very good, what I'd say, pilot or exploratory work. Well done. Thank you. We'll hand over to the next one.
Thomas, thank you so much for joining us. If you would just mind just kindly leaving the session, if you just press the red minus button, and that's perfect. So next up, we should have Struan. So Struan, are you able just to join the call? Perfect.
Morning.
Morning, Struan. Thank you for joining us.
Thank you very much for letting me present. Sorry. Is that coming up at all? Why am I struggling?
Not yet. So if you press the screen share button at the bottom, Struan, so it's like the third icon along. It's the one that looks like a computer screen. So if you press that, and then you should be able to choose if you share your whole screen or just your Chrome tab or Firefox tab, whichever browser you're using. So imagine if you share the whole screen and then you get the you get your PowerPoint presentation up. Is that working?
No, I'm pressing the right things, but it's not coming up. I wonder why that is.
No worries at all. Just while you're doing that, Struan, just for Professor Green and Ms. Zachou, are you guys happy? At the moment, I think we're sticking to about sort of 12, 13 minutes of presentation. I think there's
as long as the people are happy. I think it's nice to give people a chance to present properly. We're having obviously some issues with loading up an IT, and it's nice to ask a few questions. Obviously, people have put a lot of work into this. So if people don't mind, if you do mind and you've got to rush off to lunch or you've got other engagements, please say on the group chat. But I think it's nice to give people a chance to present properly. Calum, if it's okay with you.
No, that's exactly it. That's why I've not kind of interjected or just stopped anyone at the moment. I think there's been some really good questions.
That's reasonable. I think we've got capacity to do that. So if everyone's all right with that, I'd rather do that than cut people off. I find that.
Sorry, it just keeps on bringing me back to the same screen. I think my laptop's not allowing me to do it actually. I don't know if it's worth coming back to me. I'll try and fix it in between.
No worries. You guys reckon? We're very happy. If you want to just give it, let me just have a look at who is going to be up next and see if they're ready to go. So we've got Joseph Rassam. Joseph, you were meant to be next. Do you want to just comment if you're there, Joseph? Just waiting for me to join.
Okay, I've done it now. Yeah. Is it coming up now? I had to change my settings.
That's perfect. That's right. As in that we can see your screen. So if you get
that's perfect. Well done, Struan. Struan, while we're waiting, can I ask what your bunting says behind you, please?
Yeah, it's my wife's birthday, so it's still not come
happy
down.
birthday from all of us.
Right,
okay,
I'll
great.
pass that along. So sorry about that. My name's Struan. I'm currently at Salford as a senior clinical fellow, but I'm just presenting some research I've recently done at Bolton about whether ethnic minorities are at a greater risk of presenting late with acute scrotal pain. The reason I did this study was essentially in talks with my consultants, we felt that we were doing more orchidectomies secondary to testicular ischemia because of torsion in ethnic minorities. And we wanted to sort of figure out if that was fact or not. As we know, acute testicular torsion is a common urological emergency. And the two important factors about whether the testicle's salvageable or not is degree of torsion, but also time between the onset of pain and their presentation to health services. We know that if men present within 6 hours of the initiation of pain and have an exploration promptly within 6 hours, they have a 97% chance of having a salvageable testicle. In terms of Bolton, there's a slightly larger section of ethnic minorities in Bolton, mostly due to an increased number of South Asian residents, but otherwise it's relatively similar in distribution to the rest of the UK. And why is this important? Well, we know that ethnic minorities do tend to present later with lots of health conditions, particularly cancers, but the majority of the research in the reading that I've done has been based in the US. We obviously know there's significant socioeconomic factors that would implicate that in the US, but we do know that in the UK, ethnic minorities do suffer from health inequalities from the Marmot Review in 2017. Testicular loss, it has got a debatable effect on future fertility. However, it does have a definitive psychosexual impact on the young men. And there's no similar studies to this to date. So what we did was a retrospective cohort study over 5 years using the emergency theatre booking system. We included all patients undergoing emergency scrotal exploration for which the indication was suspected acute testicular torsion. There's quite a few exclusion criteria, but the main ones I want to point out is the fact that we didn't look at representations, i.e. missed torsions, so that they've been previously reviewed by another doctor. And we didn't include patients where there wasn't an accurate documentation of the time of onset of pain. What we looked at is we looked at the medical notes. We found out the ethnicity, which is generally given via voluntary information given at the front desk of A&E when they book in. And we looked at the surgical note to see the outcome of surgery. But the main thing we looked at is time to presentation. And what I mean by that in minutes is the time between the onset of the acute scrotal pain as documented by the clerking to the time of attendance at A&E, i.e. the time that they booked in at A&E. We also, just to try and look for consistency between our two groups, looked at time to surgery, i.e. the time in minutes between attendance and starting the exploration. Of course, we wanted this to be consistent within the same group so they were getting the same urgency of care. So we therefore had two groups. We had white British patients and ethnic minority patients. We looked at all exploration findings and compared the two groups in terms of their time to presentation. And we also looked at those who were just found to have torsion with or without testicular loss. And we called those two groups WBT and EMT. So they were the ones that only found torsion. That data was all quite skewed. And then therefore the most sensible test to compare the two was a Mann-Whitney U test. We compared time to surgery, again, hoping that that would be similar. And we did a direct comparison of incidence of testicular loss secondary to torsion. So results, well, we had 144 patients in total, so that's about 2.4 per month, so 1 every 10 days. And Bolton's got quite a young population, so that's about right, at least it feels about right. But sadly, once we applied exclusion criteria, we ended up with 94, and that was obviously because of a lack of documentation of accurate time in the most of them. That gave us 65 white British patients and 29 ethnic minorities. And as you can see, the age and time to surgery was relatively similar. That time to surgery might seem like quite a long time, but if you think about the time they wait to see an A&E doctor and then a urologist and then go to theatre, it's actually okay. It's not brilliant. Of those 94 patients, 51 were found to have torsion with or without testicular ischemia, and 33 were white British and 18 were ethnic minorities. And again, the populations were relatively similar in terms of age and time to surgery. And our results, well, median time to presentation for all explorations was 19 hours for ethnic minorities compared to 4 hours for white British patients. And that was obviously statistically significant. And if we just look at the ones that found to have torsion, it was 17.5 hours, the average time from onset of pain to presentation to hospital in ethnic minority patients in orange there, versus 3 hours in white British patients. So what did this mean? Well, it meant essentially that ethnic minority patients were 13 times more likely to require an orchidectomy when they presented with torsion. They were much more likely to present late, and that was the cause of that increased risk. And all the patients who required an orchidectomy presented after 6 hours, as the data previously had suggested. So what does this mean? What can we do about this? Well, if you look at the factors here, essentially the important thing is a young boy or a young man's recognition that acute severe one-sided scrotal pain is an important urgent emergency. So that's education-based. But if they're younger, they have to have the ability to easily tell a caregiver, a teacher, or their parent that they have a sore scrotum, and their parents or teachers need to know that that's important. So what can we do about that? Well, for us, it's mostly education, I think. So clinician awareness is important, like presentations today, and we have a manuscript accepted for the GCU. We've written to our local government, as well as local MP and the Secretary for Health and Secretary for Education with regards to our research. In fact, the National Sexual Health Guidelines don't include anything about acute scrotal pain. And we've created a leaflet which we're giving out to local mosques as well as schools. And this is a fact sheet for both boys, teachers and parents to let them know about the urgency with which they should treat acute scrotal pain. These are my references, and thank you very much for listening.
We need to link up because I've spent the last 2.5 years designing a teaching program for schools that's being rolled out nationally, specifically on this. But we couldn't find, like you couldn't, very much data on ethnic minorities because, so it's really interesting that there's two ways of looking at this. You're absolutely right. It's very worrying that this is the case, but I'm impressed that you're white British know to get to hospital so quickly. I've never seen data to show that the average for that's 4 hours. You know, most people are taking, if you look at French, Canadian, American, UK, European studies, they all take much longer. So I'm just interested why you're white British are so good at getting to hospital. They know about it so much and getting to hospital so quickly. Can I just ask one question about your ethnic minority group? Obviously, that's very wide in most centres. We in London have got about 120 different language speakers. You're saying majority of your speak the same language. So if you translate it into a educational package, you think you could access the majority of your, what you say, ethnic minority, but they're mainly one group of ethnic minority patients, are they?
No. We've used our Bolton translational service. We've got a great translator in Bolton called Deepak. He works full time and he speaks 9 languages. So all 9 languages that he speaks, we've translated them so far, just out of ease. In terms of the distribution of ethnic minorities that were in this study, there's not enough power in the numbers to be able to describe that. Now, I can tell you that they were majoritively Pakistani and Indian, but we're talking about numbers of 1 Afro-Caribbean and 1 something else.
Exactly.
So I don't think this study could say that.
No, it's too small, isn't it? Can I ask another question then? Do you know if they are new immigrants, are you new to the country with language difficulties, or I mean, are you going to do any work on that to look at that anymore, or whether they're just ethnically different but have been living in England or the UK for either 1 generation or 2 generations? Can you go on to do more work on that?
Yes, I didn't look at it at this stage, and the reason would be difficulties. So you get into a bit of ethics because a lot of ethnic minorities don't want us to know that information because they feel that that's an unsafe thing to tell us.
Of course,
You would have to get their permission to start with. But I think that's an important thing to look at in terms of education. And that's really the only thing that we can change here, because I mean, a lot of studies that have looked at this before talk about culture, but as a Scottish male, I've got no idea where to even begin with that. So I think in terms of education, that's the only real thing that physically we could change right now. And so something like what you're doing is essentially what we want to do in our region. Just as a point, the reason I think that the numbers for white British are so impressive is partly observational bias. Because if you think about it, the SHO, when they write down, they're going to say, oh, it's only started an hour ago, let's get them to theatre. What they write down in their clerking is probably much more fantastical if it's a short period of time. I think if they'd said yesterday, this morning sometimes, then I would exclude them because it wasn't.
I agree with you about that, because that's the problem we found whenever we've done studies like this. It's actually the quality of data of how long they've been waiting. If you look at that from most studies, it's very hard. And you're absolutely right, because if it's a very short time, people start accelerating the clinical process to get them to theatre, don't they? And I have to say, I'm sorry to say that I think if people say, well, it's over 12 hours, over 24 hours, people may not be as keen to rush people to theatre. So again, it immediately produces a time bias, doesn't it, into the study. So I agree with you entirely. There could be bias there, but I have to say, well done on doing this work. It's very interesting and excellent that you've done this work, because it is hard work to do, as you say, for the ethical reasons you're laying out. Alexandra, have you got any questions or?
No, it's a very impressive study, Stuart. So thank you very, very much. We are here to protect testicles. It is a bit of a tricky situation, but in this day and age, you have to be extremely mindful. And I would say, as Prof. Green was saying, it's not a question about like a white British person, because the socioeconomics and educational background should be the same for everybody. Because so well done, and it's going to be very important, the next step of implementation. So thank you.
And Struan, just for your information, we're changing a lot of the NHS websites, etc., to try and do acute testicular pain, because as you know, it's only on testicular masses at the moment. So we're getting the website changed and everything. So we've been working on that again for about 1.5 years, but you're very welcome to join the team, or your team's very keen. We're happy to obviously make that collaborative to get that sorted out.
Definitely.
Great. Let's move on then to the next one. Thank you.
Thank you. Thanks, Calum.
Fantastic, Stuart. Thank you for joining us this morning. So if you could just kindly, perfect. Thanks again. Okay, so next up we've got Joseph. So Joseph, right on cue. Thank you, Joseph.
Hello. Hi there.
Good morning, Joseph. Thanks for joining us this morning.
Let me just get my screen share.
So so it should be from so the third icon along, there's a computer screen with a red line through it.
Yeah.
So if you click on that and then click on share whole screen.
Entire screen. Okay. Is that working?
Perfect. So we've got your screen share up here now, and now that's it. So we double click on it, and that's working perfectly, Joseph. So
everyone can see my first slide. Okay, so I'm Joseph Rassam. I'm a core surgical trainee currently in the East Midlands. Today I'll be presenting our project on immediate post-operative phosphodiesterase inhibitor therapy following robotic assisted radical prostatectomy and assessing the erectile function outcomes associated with timing of starting therapy. So the National Prostate Cancer Audit in 2019 showed that 33% of men treated for prostate cancer underwent a radical prostatectomy. RAP, robotic assisted radical prostatectomy, is becoming an increasingly practiced surgery due to its minimally invasive nature. It's been shown to have equal or potentially better outcomes to more traditional types of prostatectomy, and is also shown to have shorter hospital stays due to kind of quicker recovery times. However, there is still an issue that remains around patients who have erectile dysfunction following RAP, which is what we aim to examine today. So a meta-analysis in 2012 showed that 37% of men following RAP about 2 years post-op would still have issues with erectile dysfunction. This has a major impact on patients' quality of life and functionality for men. So patients are routinely given phosphodiesterase inhibitors post-op in order to try and combat erectile dysfunction. However, there aren't any clear guidance as to when these should be started, which is what we try to look at. So phosphodiesterase inhibitors work on the nitric oxide pathway by inhibiting the breakdown of cGMP to GMP, which basically causes a cascade of events that lead to smooth muscle relaxation, vasodilation, and erection. So our study aimed to assess whether there was an association between the timing of initiating the phosphodiesterase inhibitors and erectile function. And there were some secondary outcomes as well with regards to whether the timing was associated with a difference in adverse events and also continence outcomes. So we prospectively collected data from a single surgeon at a tertiary center, which was Adam Brooks Hospital, and this data was retrospectively analyzed. We measured the erectile function and continence outcomes with the EPIC 26 score, which is a validated questionnaire. And we measured preoperative metrics such as age, BMI, Charlson comorbidities, and also their nerve-sparing status. And post-operatively, complication rates, readmission, and discontinuation of medication was also measured. So a total of 187 patients were found to have had a RAP within a 2-year period, and 158 of these were started on a phosphodiesterase inhibitor post-operatively, and these were followed up at a median of 43 days post-op. So with these patients, we stratified them into 3 groups based on the timing at which the medication was started. So immediate, which was 1 to 2 days post-op, early, which would be 3 to 14 days, and late, which is more than 14 days. As well as this, the nerve-sparing status was also stratified, so no nerve-sparing, unilateral and bilateral, and there was a fairly even kind of sample size across these groups. With regards to the patient demographics, the mean age was about 63, the BMI was 27, and only 9% of patients had one of the Charlson comorbidities. But most importantly, there wasn't found to be any statistically significant difference between age, BMI, comorbidities, and the preoperative erectile function scores amongst the 3 groups. So looking at our primary outcome, which is the erectile function, if we look at the first graph here, so the most exaggerated effect was found in the bilateral nerve-sparing groups. So the first graph shows on the y-axis the mean drop in erectile function. So the x-axis, you can see there's an immediate, early, and late. So the lowest drop in erectile function outcomes was seen in patients started on medication immediately post-op in the bilateral nerve sparing group. And this can be quite nicely seen by the orange bars, where you can see if it started immediately, this drops less than if it started in the early phase compared to the late, which was a statistically significant thing. And the second graph shows return to baseline erectile function, which essentially shows the same trend, that if medication is started in the immediate phase, particularly in the bilateral nerve sparing groups, this increases return to baseline function. So with regards to our secondary outcomes, so the continence outcomes were also positive with regards to starting medication early. So the green bar reflects a return to full continence, the red bar reflects a return to social, and the orange is incontinent. So if the medication was started immediately or early, this was associated with a high proportion of patients who returned to full or social continence when compared to patients who were started late. And with regards to adverse events, which has been concern amongst kind of clinicians when starting medication early, there wasn't any statistical difference between complication rates or readmission rates between the groups, which has been a concern for clinicians starting medication early. So overall, our study shows that there's an improved erectile function outcome in patients who are started on phosphodiesterase inhibitors immediately post-op. And this is specifically statistically significant in bilateral nerve sparing surgery, which fits in with the mechanism of action. With regards to our secondary outcomes, it showed that there was improved continence outcomes when starting phosphodiesterase inhibitors immediately, and there wasn't any associated adverse events with starting them immediately after surgery. So we would suggest that, particularly in bilateral nerve sparing surgery, that phosphodiesterase inhibitors are started immediately to maximize erectile function outcomes and continence outcomes. Thank you.
Fantastic, Joseph. So just putting it out to the floor.
Lovely.
Yeah.
So great. That's lovely, Joseph. So can I ask you if you have preference to a particular phosphodiesterase inhibitor in your center?
No. So I'm fairly sure it was mainly taldilafil as opposed to sildenafil.
Do you have any ideas why would that be chosen, perhaps?
I'm not too sure, to be honest, with regards to why clinicians have chosen one over the other, but that seemed to be the preference amongst the clinicians at Addenbrooke's.
Okay, so it could be that it is active for a longer window period, so more spontaneity, so things can be working for longer, perhaps. Yes. And are you familiar with any other techniques that the surgeon can employ to help the penis be rehabilitated when such a significant operation takes place?
So there are kind of medication-based things like pumps, which can be used post-operatively. But I don't know whether you're asking more specifically to do with the operation itself.
No, I think that's what I was alluding at, because just like helps, like, as we say, the health of the penis itself. Do you have any ideas about possibly starting these tablets before the operation?
So we don't, but that is an interesting point, which would probably warrant further research. But that's not something that we kind of looked at during our study.
And if you had not used the EPIC 26 questionnaire, is there any other questionnaires you could perhaps contemplate using?
So there is the IIEF score, which can be used for erectile function outcomes. But other than that, I'm not familiar with other scores.
That's brilliant. And it is the right questionnaire. It is designed for the purpose. So great. Thank you.
Okay. Thank you.
That's absolutely great. Thank you. Is there any more questions from Prof. Green or Ms. Zachou? We're finished. That was fantastic, Joseph. Thank you so much for taking the time to come present to us this morning. If you could just kindly hit the minus button and remove yourself from the group, that'd be perfect. That's great. Thanks again, Joseph. So next up we have Dominic. So Dominic, I'm just going to click on your link here, and hopefully it all works. All right, here we go.
Morning.
Morning, Dominic. Thank you so much for joining us. Can you hear us all?
Yeah, can everyone hear me all right?
Yeah, crystal clear. So Dominic, so just to talk you through, so on the bottom you should have 4 icons, the third one being a computer screen with a red line through it. Perfect. So that's it. So we can now see your screen share. And so if you get your PowerPoint presentation up on your screen, that should be what's filling that screen.
Yeah, it's up. Can you see the presentation?
Not yet. Do you want to just double check when you press screen share? There's 2 options. There's one to share your whole computer screen and one to share your internet browser. Just make sure you've picked the whole screen rather than the internet. That's it. Perfect.
Yeah. Are we on?
So, let's just see.
Okay, great. Thanks. So my name's Dominic. I'm a CT2 currently working in urology at Broomfield Hospital, and I'll be presenting a systematic review that we have performed looking at radiologically guided aspiration and sclerotherapy of symptomatic simple renal cysts. So just a quick overview of the topic. Renal cysts themselves, incredibly common, and obviously everybody will be seeing these on scans multiple times a week, no doubt. Acquired lesions of the kidney thought to result from a weakening of the cell basement membrane, distal convoluted tubule, or the collecting duct of the kidneys. Very, very common in adults and increasing with an advancing age as well. So over 1/3 of people over the age of 70 are thought to have these simple renal cysts. In terms of classification, the Bosniak Classification is something you'll all be familiar with, and Professor Morton Bosniak on the top left of your screen there introduced the idea in 1986. A CT classification of renal cysts, 5 classifications, and classification 1 and 2 particularly are defined as simple renal cysts, benign in nature, and they're the simple cysts that we'll be looking at in this systematic review. So the vast majority of these cysts are asymptomatic in nature. They're usually incidental findings on scanning for other sort of abdominal pathology or urinary tract pathology. Having said that, reportedly 2 to 4% of patients with these cysts will develop symptoms of some kind. The vast majority of those will present with loin pain or renal angle pain. In a distant second, patients present with hematuria, and other symptoms such as a palpable mass is uncommon, or recurrent UTIs. And very rarely, patients can present with a pelvic ileal obstruction as well, obstructive uropathy. Developing symptoms with these cysts is the only real indication for intervention. Otherwise, they are either not known about or managed conservatively once found. And with regards to intervention, the 2 predominant options are either surgical, and with this we talk about open or laparoscopic, which I won't really touch on too much or go into detail with, and the other being the percutaneous aspiration therapy, which we'll explore further. So just an overview of aspiration sclerotherapy. As mentioned, it's under radiological guidance, and almost always this is done with ultrasound, as you can see on the right side of the screen there, with the needle puncturing the cyst. It can also be performed under CT guidance as well. It's a minimally invasive procedure. It's by no means new. It's been around for 40 or 50 years, and aspiration alone has been found to have very high recurrence rates. Literature reporting anywhere between 70 and 100% of cysts recurring just after aspiration. This is thought to be because the epithelial lining of the cyst itself has secretory cells, which obviously just by purely aspirating the fluid, the cells will resecrete and the fluid will accumulate. The second part of this aspiration sclerotherapy treatment is obviously the injection of the sclerosant into the cyst cavity following aspiration. Data reports that this increases the efficacy of the procedure, the idea being that those epithelial cells undergo a necrosis and are no longer able to resecrete into the cyst cavity. We'll touch on some variables of the procedure as we go through the results, but obviously there's lots of different sclerosants that can be used, and lots of variables to take into consideration as well, such as number of injections, the length of time that the sclerosant remains in the cavity, and so forth. So aspiration sclerotherapy, again, often used as a first-line treatment for cysts at the moment. Although there's a lot of evidence behind laparoscopic deroofing or decortication of cysts being more effective than the percutaneous therapy, but because of the sort of minimally invasive nature of aspiration, use of a local anaesthetic, it tends to be seen as first line often still. So in terms of the methodology for the systematic review, the reason why we performed it is, although, like I said, it's a well-established procedure, very well described in the literature, and there is a lot of reports on the literature, the procedure itself. There's a very low amount of high-level evidence, and again, a real paucity of review data out there. The majority of the data is either single case reports or small case series and retrospective in nature. So we sought to bring this all together and provide some summative review data. We performed a systematic review, as I said, looking at aspiration both with and without sclerotherapy for simple renal cysts, specifically looking at the safety and efficacy. Just in terms of the methodology, followed Cochrane guidelines for the systematic review. They're the databases that we searched for our papers. Inclusion criteria were any published articles after 1990, and any case series that we included, we restricted to 4 or more patients. Data extraction done by two independent authors, and in terms of analysing the data, as we'll go on to discuss, there's a lot of heterogeneity in the reporting of the data itself, so it was difficult to pull any statistics out. So what we've done is a kind of cumulative analysis of the data, presented these as percentages and means where appropriate. We also do a subgroup analysis, as mentioned, of aspiration both with and without sclerotherapy. So this is just our literature flow chart. As you can see, a large amount of papers came through initially, ended up with 57 in total, which were included. So moving on to the general results, 57 articles included. The vast majority of these were, as I said, retrospective case theories. 2 randomized controlled trials were included, one directly comparing aspiration with and without sclerotherapy. The other was looking at aspiration sclerotherapy compared to laparoscopic procedures. Just over 4,000 patients from these 57 articles were included. And as you can see, the vast majority of those also underwent sclerotherapy. Only 242 underwent aspiration alone. In keeping with the majority of patients presented with pain, which was the triggering indication for intervention, followed, as I said before, by hematuria and other symptoms. Average follow-up was nearly 20 months post-procedure. All but 5 of these studies used ultrasound guidance. The other 5 used CT to perform the aspiration sclerotherapy. Ethanol was by far and away the most commonly used sclerosant at varying concentrations, but there are other sclerosants used, things like phenol, tetracycline, minocycline. The list is sort of a little bit endless, and a lot of the studies are people trialing new sclerosants. So overall, before we look at efficacy in terms of cyst resolution, just symptom relief, approximately 80% that applies to those undergoing sclerotherapy as well as aspiration were experienced complete symptom relief, compared to only about 20% of those undergoing aspiration alone. And one of the things that we really struggled with in this systematic review was the definition that papers used for either success or failure of treatment. As I mentioned before, there's a lot of heterogeneity, and there was really no consistency throughout the papers. Some using a target of 30 or 50% reduction in cyst size with or without resolution of symptoms, others defining it as a complete resolution in cyst size. And that really was the challenge in terms of trying to analyze the data, as we were unable to really compare too much across the board. So just touching on safety before we move on to efficacy, throughout all of these, just over 4,000 patients, there were 457 complications reported. Within the aspiration sclerotherapy group, the complication rate was just below 10%. And as you can see, aspiration alone produced a higher complication rate. All but 4 of these were what they classed as minor complications. Majority were pain, which were either mild and transient in nature or a low-lying fever. The 4 complications reported as major, 2 of those were an episode of sepsis, which was successfully treated with antibiotics, 1 retroperitoneal hematoma, and 1 psoas abscess, but they didn't provide any follow-up on those 2 patients. So looking at efficacy, and this needs a little bit of explanation. If you look at the top area of the graph, as you can see, we've got 3 different categories for defining treatment success. The reason we implemented this is, as I said, there was a wide range of different definitions of treatment success. And so by categorizing it in this way, we allowed ourselves to be able to group all of the studies together. So as you can see, those reporting complete disappearance of a cyst, 60% in the aspiration and sclerotherapy group. However, that was restricted to 41 of the 57 studies. And as you can imagine, as we broadened the definition of treatment success up to an 80% reduction in cyst size, and then onto a 50% reduction in cyst size, you get more patients included in these categories, as you're more likely to be able to define them as successful. But we were also able to include more of the overall studies, and the green bar on the far right, the greater than 50% reduction in cyst size plus resolution of symptoms is what that is. We were able to include all 57 studies. So the real figure we're looking at there is the 87.7% of what we're defining as treatment success. And I will talk a little bit more about the definitions on the next slide in terms of how we introduce definitions for success. The figures on the right, that 79.6% was grouped together as sclerotherapy as well as aspiration, so that's not on the subgroup analysis. Again, using that definition of greater than 50% reduction in size and resolution of symptoms. Failure rate was again difficult to quantify, as different studies again define failure in a different way. So what we've done is just use the study's own definition of failure, and that gave us a reported value of around 12% only for aspiration sclerotherapy, but failure as high as just over 70% when aspiration was performed alone. And that's similar data to what was reported, again, I mentioned anywhere between 70 and 100%. So in terms of our discussion, as I already mentioned, defining treatment success was a difficult point for us. We decided that symptom resolution was an absolute key to include in the definition. The main reason being that developing symptoms was pretty much the main trigger for intervention in the first place. The other aspect is defining how much you need to decrease the size of a cyst in order to classify it as successful. One aspect we took into consideration was the fact that by nature these cysts are benign, as we talked about in the classification. Therefore, we didn't feel that a complete resolution of the cyst is necessary. And going on the majority of what was reported in the literature, we plumped for a greater than 50% reduction in size plus symptom resolution. Following on from this, we've also suggested in our paper the use of 3 definitions of success, which may be used going forward in the literature and would actually allow, if incorporated, for comparison across any studies that are done in the future. And as you can see, we've got 3 definitions of success: treatment, radiological, and clinical, and they are defined by the size of the reduction on radiological follow-up and also whether or not the symptoms recur. So overall, as mentioned, broadly speaking, aspiration sclerotherapy in symptomatic renal cysts, we found a relatively high success rate of nearly 90%, low complication rate of under 10%. Looking at aspiration alone, as expected, we got less favorable results. But because of that large discrepancy in population size, as well as the differing ways that studies reported it, we've not obviously done any direct comparison between the two and can't, definitively draw conclusions, although there are, a large difference in the percentages quoted. Other things that are important to consider, which we touch on in our discussion in the paper, but we're not able to definitively draw conclusions on, are variables in the procedure. So the type of sclerosant used, obviously the majority use ethanol, but as mentioned, there's many others that can be used. The volume that's used, the number of times people administer the injection itself, and the length of time with which the sclerosant is left in the cavity itself. Variables that differed a lot between studies, and unfortunately, there's no studies out there at the moment directly comparing these controlled variables, so unable to draw conclusions on it from our paper at the moment. But it's certainly aspects that need studying in the future in order to actually refine the procedure itself. And then limitations of our paper, obviously previously mentioned, the majority of the literature out there is retrospective in nature. It's small studies, often sort of 4 or 5 individuals included, and there's obviously a complete lack of control across the studies. So they're all things that we need to take into consideration with this paper. So take-home messages from me really is that we conclude it to be a safe and effective first-line therapy in symptomatic renal cysts. The use of a sclerosing agent appears to be essential in order for these high efficacy numbers, although obviously we weren't able to provide definitive data in terms of statistical analysis. Going forward, procedural variables need to be refined. As I said, the novel definitions of treatment success that we've proposed going forward to be used. And again, the limitations mentioned. From me, so any questions?
Thanks, Dominic. I have to say, unless anybody's done a systematic review, they don't realise how much work you obviously put into this, going through the papers. It looks easy when you've laid it out so well, but you must have put hours and hours and hours into this. So well done. Thank you very much for that.
No, thank you. I'm just struggling. I just want to get back so I can see all your faces.
Okay.
Hi, there you are. Yes, you're absolutely correct. Yes, ours is an understatement, but thank you very much.
Exactly. So well done. It's very impressive. Well done. I mean, the problem with all these things is it's kind of biased towards good results, isn't it? So we'll put that to one side.
Correct. Yeah.
But what you've shown is, as always with these reviews, it's the heterogeneity. You've found the problems. You've had to develop a framework to try and judge things against each other. So, a massive amount of work. So thank you very much. Can I just ask you a really practical question? Once you sclerose cysts, they're always going to look weird, aren't they? So you're going to follow these up, and then in 10 years' time, what's to think? Somebody's not going to think it's a horrible, funny thing that they need to excise or remove because they're worried it's cancer down the line. That's why I'm just always worried with sclerosing large cysts.
No, it's a very interesting question. It's actually not something that I had thought about, because not something I'd come across in any of the readings. So it's a very good question. And as mentioned, all of the follow-up, like you said, it's all sort of pushed towards the successful stories, isn't it? So all of their follow-up was just whether or not there's been a reaccumulation of the cyst. And there wasn't really any mention on what they look like, even if they haven't reaccumulated. So I have to confess, it's not something I know. I've not seen them on follow-up.
I mean, just for the people on the call, anything like ultrasound treatment, freezing small tumors, all these things. It's the follow-up that's the nightmare, really. You're right. It's even defining success is hard for aspiration sclerosis of cysts, but it's the follow-up which is also a headache that we have to consider as well from that point of view. Are you going on to look at your figures against laparoscopic marsupialization, all these other things, or is that just too much to take on?
It was probably part of the original plan. I'll probably take a little bit of a no. So it stemmed from obviously when you look, there's data out there already comparing it against laparoscopic, and I think that's probably preferable data for people at the moment, because people, I imagine, are keen to crack on with laparoscopic rather than trying to prove that this in itself can be an effective treatment. But it's certainly something that I'm going to consider moving forward in terms of the comparative. As I said, there's a systematic review that I was looking at laparoscopic deroofing, and one of their recommendations at the end was, despite their high efficacy and high safety, etc., they still do recommend aspiration sclerotherapy as first line in majority of cysts. Other than the question is the subsequent treatment, if that to fail or recur, do you go back to doing aspiration sclerotherapy again, or do you then progress? And so their recommendation from the systematic review was that this still takes precedent as first line. But yeah, I certainly like to look at it more comparatively going forward with other treatments.
But I agree also, but it's especially reassuring in the comorbid patients, isn't it, that can't have deroofing, and that you're going to persuade definitely to have, you know, this first line, aren't you? So I think it's a great piece of work. Well done. It was good to see that, as you say, they were large kind of symptomatic cysts, because the problem with this is, you know, there's radiological creep, especially in the private sector, where people will start aspirating, sclerosing smaller cysts, and, you know, ones that have got very minor symptoms. So we've just got to be a bit careful about that as well, I think. So well done. It's a really lovely piece of work. Thank you very much indeed.
Thank you very much. Appreciate it.
Dominic, thank you so much for joining us this morning. If you just kindly press the remove. Yeah, so there should be a kind of a stop button, like a round red dot with a minus sign through it. So if you just press that, and that takes you out.
I'll just leave and come back. But thanks anyway.
Thank you for your time, Dominic. Okay, fantastic. So and now we're on cue.
Hiya.
Anil, good morning. Thank you so much for joining us.
Good afternoon. I'll try and share my screen if I can.
You through. So 4 icons on the bottom. The third one along should be a computer screen with a red line through it. So if you press that, and there are 2 options. One is to share your entire computer screen, and one is to share your browser only. So if you click the entire computer screen, perfect. And just to check, you can hear us. We can hear you.
Great, cool. So hi, my name is Anil Christian. I'm a core surgical trainee in the West Midlands, and today I'll be presenting my team's project titled The Safety and Efficacy of Bipolar versus Monopolar TURP in the treatment of moderate to large volume BPH. So BPH is defined as the progressive non-malignant growth of prostatic tissue, which often results in troublesome LUTs due to bladder outlet obstruction. While various surgical modalities exist for the treatment of BPH, TURP has long been seen as a gold standard for moderate to severe LUTs and a prostate volume of 30 to 80 mil. For larger volume prostates, open prostatectomy and laser enucleation have both been advocated. However, laser is not widely available across centres, and studies have demonstrated that TURP has comparable outcomes to both of these methods. However, the evidence regarding the different types of TURP technique for larger volume BPH is limited, and therefore, our aims were to perform a systematic review and meta-analysis of comparative studies evaluating the outcomes of monopolar and bipolar TURP in the treatment of moderate to large volume BPH. So the study was performed according to the standards in the PRISMA statement, as well as the Cochrane recommendations for intervention reviews. Our eligibility criteria were all RCTs and observational studies that evaluated the outcomes of monopolar and bipolar TURP for moderate to large volume prostates, and only studies that included patients with a prostate size of greater than 50 grams or 50 mil were considered for analysis. In terms of the outcome measures, so our primary measure was efficacy, which we defined as the maximum post-op urinary flow rate, also known as Qmax. And secondary outcomes included the duration of catheterization, length of stay, the incidence of TUR syndrome, acute urinary retention, clot retention, and post-op blood transfusion. So 2 independent authors performed a comprehensive search strategy of various databases, followed by data extraction. And the outcome data were reported as the mean difference for continuous variables and the odds ratio for dichotomous variables. The software review manager was used for data synthesis. Heterogeneity was assessed using the I-square statistic, and a sensitivity analysis was also performed. So looking at our initial results, so our literature search yielded 642 articles, and from these, 7 studies ultimately met the eligibility criteria, 3 of which were RCTs and 4 were retrospective studies. So from the included studies, we had a total of 496 patients, of which 244 underwent monopolar and 252 underwent bipolar TURP. So table 1 here presents the baseline characteristics of all our included studies, while table 2 shows the baseline demographics of our patients, which included baseline PSA and IPSS, which were comparable across each of the studies. You can also see that the mean prostate volume in each study, which ranged from 76 to 129 grams. The risk of bias was also calculated using the Cochrane tool for RCTs and the Newcastle Ottawa scale for observational studies. Cool. So if I move on to the main results, so firstly, our primary outcome measure, which is efficacy, we found that there was no significant difference in the Qmax between the bipolar and monopolar TURP group at either 3, 6, or 12 months post-op. Bipolar TURP was associated with a marginally significant decrease in the duration of catheterization compared to monopolar, and was also associated with a significantly shorter length of stay. Monopolar TURP was associated with a significantly higher risk of TUR syndrome compared to bipolar. However, there's no significant difference in the risk of acute urinary retention, clot retention, or blood transfusion between the two groups. So to the best of our knowledge, this presents the first meta-analysis comparing the outcomes of bipolar to monopolar TURP in the treatment of moderate to large volume BPH. And our analysis suggests that bipolar is superior to the monopolar TURP group for the treatment of large volume prostates. And that's due to a reduced incidence of TUR syndrome, a shorter duration of catheterization, and also reduced length of stay. There were some limitations to our studies. So firstly, due to a limit on the number of included studies that we could find, as well as some heterogeneity in the literature, we used a cutoff of 50 grams of prostate volume. More recently, the EAU guidelines have defined a large prostate as being greater than 80 ml, and they've recommended TURP as one of the suitable modalities for this. Also, only four of our studies were non-randomized, and so there's an increased risk of selection bias with those, and as only 3 were RCTs. So to conclude, we recommend that further high-quality RCTs with adequate sample sizes and a stricter definition of prostate size are required to compare both monopolar and bipolar TURP to both open prostatectomy and laser enucleation for large volume prostates. And thank you very much for your time. Any questions?
Well, thank you very, very much. So in your practice, what prostate size is large, would you say?
So I think obviously going off the more recent EAU guidelines, they've defined that as being greater than 80 ml. Although when we did look across some other studies and guidelines, there was some incongruity between the results. I would say 80 ml would be a good cutoff to use, and thankfully amongst our studies, the average and the median volume of prostates included was roughly around 80 ml, if not more. I guess it also begs the question about accurate measurement of prostate size, and where some clinicians will just go off DRE. It's a question of, do we go for ultrasound or an MRI to accurately categorize this?
Right. And so it was very interesting to see that you used very nicely different statistical structures to analyze your data. But talking about the surgical approach, what type of open operations do you know for prostates, enucleations really?
So I know you can go for a suprapubic approach for open prostates. I'm not sure if that's one that's more commonly used for the open prostatectomies.
Right. And what is the main difference between a bipolar and a monopolar TURP?
So bipolar obviously uses a bipolar current, and as a result of that, you can use normal saline for the irrigation fluid, whereas for a monopolar, you need to use a non-ionic irrigation fluid, such as glycine or water, which obviously is hypertonic and increases the risk of TUR syndrome as a result of that. Beautiful.
And in terms of follow-up, just to deem what kind of operation is a successful operation when you're de-obstructing, a lower urinary tract by operating on the prostate on a benign setting, how many years afterwards you have to follow them up and see what's happening?
Yeah, so I think obviously for more reliable results, you would like to have at least a 5 to 10 year follow-up, and the longer the better. Obviously, one of the downsides to TURP over something like the new methods like laser is there's a small risk of reoperation, which I think is around 1% per year. So yeah, a longer follow-up, if further RCTs could look at this, would definitely be grateful.
Can I just butt in?
Yeah,
What One, I thought there were some papers from a chap called around on head-to-head. I think trial is it wasn't a randomly controlled trial, but there was some work on his that I'm not sure is there, or maybe you excluded it. But secondly, do you think a trial like that is very likely? you've got 4 arms, you've got people operating on large prostates where most people think it's much safer to do bipolar. Do you think a trial that you're proposing is likely to ever happen through burst or otherwise?
I think ethically speaking, the results for bipolar and the safety benefits definitely dictate that we should be using bipolar.
Yeah, so I think just be careful if you're writing it up with your conclusions. That's what I'd say. Just be a bit careful about what you're saying at the end. That's okay.
Sure.
That's great, Anna. Thank you so much for joining us this morning. Beautifully presented. If you could just press the leave button for us. That's perfect. Thank you so much. And we should have Angus presenting next. So Angus, if you're able just to join us, we can get you set up. Fantastic.
Can you hear me?
Good morning, Angus. Yeah, loud and clear. Thank you for joining us.
Perfect. Thank you. Let me just try and share the screen if I can.
It should be just the 4 icons along the bottom. The third one across is a computer screen with a red line through it. So if you press that one.
Let's have a go. So is that sharing?
It's coming up. Yeah, perfect.
Perfect. Okay. So my name is Angus Bruce. I'm currently based in the West Midlands, similar to Anil. Thank you very much for having me on this afternoon to speak briefly about a project we did looking at the safe implementation of early removal of the catheter bipolar TURP. So as Anil's already outlined, transurethral resection of the prostate, or TURP, remains the gold standard surgical intervention for bladder outlet obstruction. Even before the situation we find ourselves in now, there's a continued drive in the NHS towards introduction of increasing day case procedures, or certainly limiting the post-operative nightly stays for patients. As of advantages, obviously, for patients and healthcare providers, it allows patients to of their own home quicker. It reduces the instance of hospital-acquired infections, which is obviously increasingly relevant, and also has a financial implication as well, with each night in hospital estimated to cost around £400. Now, there's no specific guidelines from BAUS or EAU with regards to the timing of catheter removal following TURP, and therefore it's left up to the discretion of surgeons, which often relies on their prior experiences. So you can be quite a lot of variability from surgeon to surgeon. And traditionally in the UK, there used to be the implementation of the continuous use of bladder saline irrigation for around 24 hours, followed by a TWOC on the second post-operative day. Evidence in the literature more recently suggests that actually the catheter can safely be removed sooner than that. So this is a forest plot from a meta-analysis by Yu et al. Recently in 2018. And this particular forest plot is looking at the early catheter removal versus delayed, with early meaning within 24 hours of operation. And this particular forest plot is looking at the incidence of passing inpatient TWOC, and it shows that the timing of catheter removal had no significant relationship on the success of inpatient TWOC, with the p-value there of 0.61. So what we wanted to do was to perform an initial retrospective on the practices performed at our multi-centre district general hospital. We then wanted to identify any patterns of behaviour and identify any specific cases which, on review of the notes, may have been eligible for an earlier catheter removal. Following that, we presented our findings to the department locally, trying to identify these potential cases, and then we collected data again from that point onwards to see if what we spoke about actually made any difference. So the study was performed from January 2018 to July of 2019. We had 114 patients, of which 66 had the catheter removed on day 1 and 48 on day 2. Hopefully you can see there the pie charts are summarizing the inpatient TWOC success rates according to the catheter being removed on day 1 or day 2. The percentages of TWOC success were very similar in both, 80% on day 1, 81% on day 2, and the readmission rates within 30 days of discharge were very similar as well, both for acute urinary retention and hematuria. Of note, we managed to identify 17 patients from the day 2 group who, on retrospective review of their notes, we couldn't find any reason that they could not have been eligible for an earlier catheter removal. So we flagged those up and presented them to the department, as we said earlier. We then collected data from that point onwards. We had a total number of 54 patients, which obviously is a little bit lower, partially responsible due to the reduced operating from the mid to the end point of March. But we had 35 patients who had their catheter removed on day 1 post-op and 19 on day 2. And there's just a summary of some of the demographic baselines data, so the age, the resection weight, and the pre-admission anticoagulant use. And it was pretty similar between both groups. Again, the results showed very little difference between TWOC success rates and readmission rates, dependent on the timing of catheter removal. So when we look at prior to our intervention and post, although it does come with a caveat of a smaller number included in our re-audit, we did see an increased uptake of day 1 TWOCs from 57.9% to 64.8%. However, more importantly, that also coincided with a reduction in the mean length of stay from 1.82 days to 1.35 days on average. So in conclusion, hopefully we've managed to show that the early catheter removal following bipolar TURP can be safe in appropriately selected patients. Obviously, as we mentioned, the earlier initiation of catheter removal may help reduce the rates of hospital-acquired infections, allow patients to return home promptly after operation, and also save a significant amount of money. The previously implemented blanket policy of TWOC on day 2 should be avoided. And just as a throwaway comment at the end, by definition, discharging patients catheter-free within 24 hours of their operation does raise the possibility of performing such operations, possibly as a day case procedure in the future. Thank you all very much for listening. Any questions?
Thank you, Angus. That was really good piece of work. Thank you. I mean, well done on trying to get the balancing information, either long-term follow-up of people coming back in. I thought that was excellent. And the fact that obviously you now have mapped the length of stay, now you've actually implemented it more, so well done on that. Can I just ask, who did these resections? Were they mainly consultants? They're good size resections, you're getting low complication rates, or do you have wonderful trainees? Is it you who did the resections?
I would love to take credit for that, but no, it hasn't been me. The majority of them, I did take the data. I don't have it in front of me, I'm sorry, but the majority of them were registrars. Right. I don't know if we maybe took a particularly fortunate snapshot, but yeah, I mean, I'll certainly feedback the glowing.
Very impressive. Yeah. It's very impressive. And by definition, I don't know if everybody knows, you hardly ever resect half a prostate. So you're doing 50 gram and up prostates. You know, they're reasonable sized prostates you're doing. You're getting good results from them. Can I just ask, what about the failures? Is there any way of identifying why people failed? Have you looked into that? Do you as standard have, you know, urodynamics or anything for your patients before TURP? Do you know if they've got bladder dysfunction? I was just trying to work out, you know, it's great that there's no difference, though I'm not sure it's quite powered to look for a difference. It might be only powered to look for, you know, equity of 1 day towards 2 days. But you know, how can we work on these failures and try and identify them better? Because you're right, if you're going to more day case, you want to try and stop even those 20%, don't you? Because it's horrible if they go home and have problems or whatever. So
exactly. I mean, we didn't look in terms of urodynamics, which you mentioned. We looked at things like age. We looked at the comorbidities. We looked at pre-admission anticoagulant use, and we found very little to no relationship between these factors and predicting failure. We also looked at some intraoperative factors. So if it was a particularly long or difficult operation, particularly large resection, or if there's any capsular perforation, again, there didn't seem to be any relationship with those, which does make it difficult in the future if you are to obviously pinpoint those patients which could be eligible for day case procedures.
I mean, yeah, you probably need larger numbers. Again, it could be a burst.
Exactly.
It could be a burst project, couldn't it, or something like that? Because you do need larger numbers, I think, to identify those factors and try and work that out. But I mean, that's. I mean, it's great the work you've done, but we do need to do more work on that group, don't we? Really, on the same group. Okay, that's great. That's.
Let me ask a little practical question, Angus, if you don't mind. The catheter to come out, is it after a doctor visiting the patient after the procedure? It's a nurse-led thing, or
it's doctor-led. So obviously we kind of subdivided them into, say, less than 24 hours post-op and 24 to 48 hours post-op. So the less than 24 hours would be the kind of ward round of the morning after the operation, the day before. So often it would be the irrigation would continue overnight. It would be nurse-led decision to potentially stop that at, say, 6 a.m. if it was draining relatively clearly, and then it would be a doctor-led decision to remove the catheter.
Lovely, thank you.
Thank you.
That's fantastic. Thank you so much for joining us this morning, Angus.
Thank you all very much.
So, Angus, if you're able to just press the leave button, and that just logs you out. And then next up, we've got Akash, who's right on cue.
Hi.
Good morning, Akash. Thank you.
Can you hear me?
Thank you for joining this morning. Can you hear us all right, Akash?
I can hear you. Can you?
Yeah, crystal clear. Perfect. So, Akash, on the bottom of your screen, just so you can get the screen sharing up, there should be 4 icons, the third one being the screen. Perfect.
Are you able to see my presentation?
1 second. Yeah, it's all up.
Perfect. Sorry, it's just being a little bit slow. Sorry, just waiting for it to load. There we are. Are you all able to see my slides?
Yeah, we're able to see them. Thanks, Akash.
Perfect. So good afternoon, everyone. I would like to present some work we've done on developing new guidelines to avoid routine blood tests after robotic-assisted radical prostatectomies. So traditionally, prostatectomies were carried out using an open approach, but nowadays the gold standard is a move towards robotic prostatectomies. However, the kind of guidelines around taking blood tests haven't evolved as the procedure has evolved. So current practice is all patients have routine day 1 post-operative blood tests, and all patients have routine group and screen samples taken in the pre-assessment clinic. So we carried out an audit to see whether these 2 things were still necessary. And on the back of that work, we then suggested new guidelines around which patients may best benefit from blood tests. So this work was carried out at 2 centres and included both primary and salvage robotic-assisted prostatectomies, and was carried out over almost a 2-year period. So the first audit was retrospective and included just over 1,000 patients, and they're fairly representative of the average patient nationally who undergoes this kind of procedure. So the median age was 64, median ASA was 2, and you can see their BMI and comorbidities. So out of the 1,039 patients, 100% of them had blood tests. So the bit that we're interested in is on the right-hand side, the 80% of patients, so the 833 patients out of the 1,039 who had blood tests taken, because that's just the norm. They have blood tests taken on day 1 post-op. Out of those patients, none of them had complications. And obviously, we've divided the patients further into those who went to PACU or to a surgical HDU, and there were no complications out of that group. There were those who had intraoperative concerns, for example, bowel injury, and there were those who had post-op clinical concerns, for example, worsening abdominal pain or reduced urine output. So you can see that the taking blood tests routinely doesn't really pick up any complications. And because we're taking blood tests on all patients, the specificity is 0%, and the negative predictive value is also 0%. And the reason why blood tests, just taking them unnecessarily, we think is important, is because there's a time factor involved. So for the doctor, nurse, or phlebotomist to take bloods day one for each patient, you have laboratory time involved in processing the samples. And obviously, the more samples we send to the lab, the bigger the backlog is. But perhaps more importantly is by the time the bloods have been taken, gone to the lab, processed, the result is available, and then somebody has had a look at the results and acted on it, this can lead to delay in discharge. So overall, 6% of patients had their discharge delayed by a day, purely because of waiting for blood test results. At UCH, the result is slightly higher, and that's because they operate on a Saturday. So on Sunday, the on-call team basically are obviously stretched and therefore unable to discharge as many patients. Obviously, this has a financial cost. So each stay, each extra stay in night in hospital has a financial cost. So at the bottom, you can see that around £5,000 per month is wasted due to unnecessary blood tests, delayed discharges, and also taking a second group and screen. So from our initial audit, what we want to emphasize is that routine blood tests don't add much over and beyond intraoperative findings and post-operative clinical examination. Did not catch any complications missed by clinical review. The 99.9% is because there was one patient who had day one post-operative bloods and was seen on the ward round, was discharged, and then later presented with pain, which was found to be due to a hematoma. So actually, the blood test didn't really help in that patient. So we think that the emphasis should be placed on clinical review rather than blood tests. And by reducing unnecessary blood tests will improve patient flow. There's a move towards trying to make many procedures on an outpatient basis, and reducing unnecessary blood tests will help with that. And obviously you have a national cost saving once you extrapolate this data to all centres. So with the results of this initial audit, what we did is, rather than just stopping all blood tests, all routine blood tests, we thought that people would be very uncomfortable with that. And we needed to show that this is workable. So what we did is we stopped routine CRP. We continued taking early morning blood tests. This is for the routine patients, that is. When the patients were seen on ward round, if we were happy with their clinical progress, they were discharged, and the blood tests were then chased later that afternoon. And if there were any worrying features, the patients were recalled to hospital. So the advantages of this is that we reduce the discharge delays by discharging the patients before the blood tests are back, but we safety net to ensure patient safety. However, this has had no impact on the venipuncture time and costs. So we then did a prospective audit just over a short time period, which included 133 patients. And as you can see, their demographics are fairly similar to our first audit. What we found is that the 64% of patients who had routine blood tests but were discharged later that day, before the blood tests were back, none of them had complications. But we continued doing blood tests and obviously didn't discharge for the patients who went to surgical HDU, had intraoperative or post-operative concerns. So analysing the data from this second audit, discharge delays were obviously reduced. The guidelines were 100% sensitive in diagnosing complications. and the specificity and predictive values of taking blood tests was greatly improved. So what we'd like to do next, and what we're currently doing, is stopping all routine blood tests. So blood tests will continue to be taken for patients who go to surgical HDU, who have intraoperative concerns or have post-operative concerns. But for all other patients, we'll stop taking routine blood tests and follow the new guidelines. That will hopefully reduce discharge delays and leads to saving in time and costs. Once we've done that, then we'd like to move towards a national audit over multiple centres. And I think the kind of holy grail is outpatient procedures for a number of reasons. And that's where we see the future going. And I think, importantly, this kind of concept and the way we've approached stopping the blood tests could be replicated in many other specialties. We're also grappling with how to incorporate new procedures and new ways of doing things with old ways of everyone gets blood tests. So thank you very much. I'll stop sharing. And are there any questions?
Thank you very much indeed. Can you please clarify if there are actual national guidelines stipulating the routine bloods have to be taken after a robotic-assisted radical prostatectomy?
Sorry, could you repeat that question?
Are there actually national guidelines stipulating that routine blood should be done after robotic prostatectomy, or it's a protocol based on the hospitals where these operations take place?
I am not entirely sure, I'm afraid. So I think there will be national guidelines, but I think those would probably have been followed on from, as I said, people doing open prostatectomies, but I'm sorry, I'm not entirely sure. I know that we definitely had hospital protocols, and that's what we were trying to target.
And you mentioned that you dropped the CRP checking routinely the day one post-op. So what are the blood tests that you still do routinely after an operation?
Sure. So full blood count and urea and electrolytes were the ones that we still did. And I think there was some concern amongst senior clinicians that, you know, fair enough, you've got your clinical review, you could pick up the patients who might be brewing an infection or have wound complications. But there was some clinicians who were a bit worried that we had missed the electrolyte abnormalities. But data shows that those are quite low, so less than 1% is quoted. And actually, in our small study, any patients who did have electrolyte abnormalities often had things on clinical review. For example, reduced urine output is strongly correlated to electrolyte abnormalities.
Lovely.
Can I jump in as well? Is that all right, Akash? Well done. It's a good to. I particularly like your methodology. I like the fact that you've done it as a PDSA, a Plan, Do, Study, Act, a kind of almost like a quality improvement project, but obviously with very good evidence. So well done for that, and well done for coordinating 2 centres, because I know how difficult that is as well. Yeah. So that was an excellent piece of work. So thank you for doing that. I mean, I'd say when BAUS is doing a website for projects like this, so people can learn the methodology, because I agree with you. I think the methodology you've used is very elegant, and you could use it for so many other procedures. So congratulations, but you need to get this out there, don't you, so other people can copy it. So well done. You've done it in the right way. So thank you very much for that. What do you see the challenges if somebody was going to repeat it for another procedure? How would you warn them where the elephant traps are? What are the problems that you have to get over, as it were?
Sure. So I think what we found is that the anaesthetists obviously approach this slightly differently. So you saw that I mentioned group and screens earlier on, and actually we weren't allowed to stop taking group and screens, and that was because the anaesthetist said we won't operate if there's not valid group and screens. So I think you know, the surgeons are the ones who see the patients in the morning. They can, you know, if they don't think something's right, they would still order bloods, but that's based on clinical judgment. I think coordinating different specialties where perhaps, you know, there's yeah, so I'd say it's getting everyone on board is the difficult bit.
Have they told you what when they would be happy, the numbers or the results that they'd be happy?
Yeah, I'm not sure, but it's a culture thing as well, isn't it? It's you know, they might not feel comfortable taking a patient into the operating theatre if they don't have instant access to blood.
Well, it's always the thing, isn't it? Also, it's balancing the incredibly rare situation that's devastating compared to the run of the norm where everything's going well, isn't it? And I think that's very hard, and that's a cultural thing for all of us as surgeons and anaesthetists to get our heads around a bit. It's looking at the data in that way, isn't it? Reasonably objectively. You know, you can always say, well, this could happen once in a blue moon, but you know, as you say, is it worth spending hundreds of thousands of pounds protecting against that? And that's the difficult thing, isn't it, really? But you're right. It's the other people that it's getting the whole team together and getting agreement is usually the hardest factor in any change, and getting cultural change, which is basically what you're trying to achieve here. So
yeah, definitely.
Well done. Thank you very much for that.
Thank you.
Fantastic. Akash, thank you so much for joining us this morning. If you want to just kind of press the leave button just next to your name, that's perfect.
Can I just say, are you going to finish off, Calum, or can I just say something before you do? I mean, I have to say, sorry, as a moderator, the work that's gone into this, it's very impressive for everybody. Your presentations were incredibly slick. Well done. And you also all had good knowledge of your subjects. Alexandra and myself will have to go and choose some prize winners, and we'll do this in about the next half an hour, and that'll be fed back at 3:30 unless Calum tells us otherwise, I think. But from our point of view, thank you for sending the abstracts in. Thank you for taking the time to present. I would push you also to present your work at other meetings. There's the Royal Society of Medicine now that wants to have much more virtual meetings and get people from around the country to present, and obviously there are BAUS meetings coming through, and I think the standard of all your presentations could easily get in either one or both of those meetings. So please take the comments on board. If you can tweak them, obviously make them better. That's why we're trying to feed back to try and get you to present these on national or international stages. But thank you very much for all the trouble you've taken. Thank you very much indeed.
Yeah, just echoing Professor Green's comments. I mean, it was mind-blowing how high the standard was. So just a huge thank out to Alexandra and Prof Green for giving up their Sundays today to come and help hopefully future budding urologists get their work out there and present and give some really, really good feedback points for presenting and submitting to other conferences moving forward. Really impressed as well. So thank you also to Tom Newman and the team at Access. Really impressed with how slick it's all been this morning. Clearly a thing of the future, just so you can be sat at home on a Sunday afternoon and hear, you know, high quality presentations from all the amazing work people have been doing from around the country. It's incredible, and I'm sure will become a big part of sharing urological knowledge in the future. Just very quickly, just before we round off, just to remind you guys this afternoon, so there's an asset presentation at 2 o'clock. From Proximi, the surgical summit, presenting about the innovative training opportunities that ASSET have on offer. We've got an Achieving Equality and Diversity for UK Surgical Trainees at 2:55. And then, as Prof Green said, at 3:30, we have prize presentations and the final remarks from the organisers. As far as the urology prizes going, just again want to thank the sponsors of this session, Rocamed, who have very kindly donated the winner of the urology session to go on a PCNL and endourology course. And second prize will be a Smith's urology textbook. So very generous contributions, but as I said, they're all such high standard. I'm sure Alexandra and Prof Green, if their work cut out this afternoon, of deciding who's at the top. So look, thank you all for coming. Enjoy the rest of your Sundays. Much appreciated. Okay.